Hello, welcome to my channel. So today we are going to go through physiological changes in pregnancy. So starting off first, we are going to start off with some introduction on the MCQs you are likely to be asked. So number one is that clotting factor decrease in pregnancy is which one? Is clotting factor 8, 10, 13, or fibrinogen? Then the second question is which of the following is the least likely physiological change in pregnancy? Then secondly is A is saying increase in intravascular volume, B increase in cardiopulmonary cardiac output, increase in stroke volume, increase in peripheral vascular resistance. Then the third question is what are the maternal physiological changes in pregnancy? So those are some of the MCQs will be most likely to you are most likely to be asked on the physiological changes in pregnancy. Okay, so finally on the introduction for the introduction of the topic itself, the first thing is we have to talk about is the physiological adaptation. So you have to know that the adaptation occurs in response to demand which are caused by the pregnancy itself. Okay, so one of the physiological adaptation is for supporting the fetus. Okay, so support. So that's the first physiological change. So supporting of the fetus. So in terms of volume, nutrition, oxygen, and clearance of waste. Then the next one is protection. So protection of the fetus in terms of from starvation, toxins, and drugs. Then the third one is from preparation. It's preparation. So preparation. So preparation of the uterus for labor. And then lastly, we can talk about the protection of the mother from cardiovascular injury at delivery. Of course, organs are involved, but you have to know that there is protection of the mother from cardiovascular injury. That's the most common thing. Okay. Then we have to talk of the complications as in terms of systems per system, how they occur. So on the integumentary system, so this is the integumentary system, we find that there will be stria gravidarum, so which are just stretch marks due to excessive collagen breakdown. Then we can have spider angiomata, which is due to increased vascularity. We can have palmar erythema. So palmar erythema is also due to increased vascularity. Then we can have Chadwick sign, which is also due to increased vascularity. Then we have linea nigra. So linea nigra. So linea nigra is also due to increased pigmentation. Then we have chroasma. So chroasma is also due to increased pigmentation. So chroasma or melasma. Those are some of the integumentary system changes. Okay. Then in terms of cardiovascular changes, so for the cardiovascular changes, you have to know that one of the first things you have to talk about is the arterial. So arterial, in terms of arterial changes, there will be a reduction in systolic, whilst there will also be a reduction in diastolic as well. So there will be reduction in systolic blood pressure plus diastolic blood pressure. So these ones are going to reduce. Then in terms of peripheral vascular resistance, it's also going to go down. So peripheral vascular resistance is also going to go down due to the effects of progesterone. Okay, then plasma volume goes up. So plasma volume goes up. So the plasma volume goes up about 50%. So 50% of plasma volume goes up. Okay, then we have to know that even if the plasma volume has increased, the heart rate is also going to increase, the stroke volume is also going to increase, but the MAP is going to reduce, and the cardiac output is also going to increase. Okay, so that's where now the supine hypotensive disorder comes in, which is so this is where now the this is where now the supine hypotensive disorder comes in. So supine hypotensive disorder. So the supine hypotensive disorder, also known as superior vena cava syndrome, which is due to compression of the inferior vena cava. So compression of the inferior vena cava, which allows so you have to tell the women, especially when in labor or when the pregnant starts to pregnant starts to become big, you have to allow them to lie on their lateral sides, not necessarily supine position. Okay, and when in labor, one of the changes that occurs in labor uh, are that the cardiac output is going to increase. So this is one thing. In labor, the cardiac output is going to increase. So cardiac output is going to increase due to the pain and increases with each stage. And the increase is highest after delivery due to autotransfusion after placenta comes out. So that's why even when you go through the management of a cardiovascular disease, you find that actually painkillers is actually given to reduce on the pain, and after the placenta comes out due to autotransfusion, you find that Lasix will also be given. So those ones are put in order to counteract the physiological changes, which is the cardiovascular changes in labor. So where the cardiac output increases due to pain and increases with each stage, hence causing a strain on the heart. Then the increase is highest after delivery due to autotransfusion after placenta comes out. So those are some of the things you wanted to share. Okay. Then on the respiratory cause, so the respiratory system, the aim is to optimize maternal and fetal oxygenation and facilitate the transfer of carbon dioxide from the fetus to the mother. Then anatomically, so we can have one anatomically where the diaphragm becomes dome shaped, then widened by thoracic diameter. The tide volume is going to increase by 40%. Okay, so in the respiratory system, there are some pulmonary changes you have to, pulmonary terminologies you have to be familiar with, since we talked of increase in tide volume. So tide volume, this is just air going in and out of the lungs at rest. So that's what is going to increase. Okay, then the inspired respiratory volume deep, which are just a deep breath, and the increased in lung volume. Then there will be the deepest breath out expiratory reserve volume. Then there is what we call a vital capacity. So vital capacity is just the vital capacity is a combination of the deepest breath out, the deepest breath someone has taken out, which is the expiratory reserve volume, and the inspiratory capacity or the inspiratory reserve volume. So we have two: expiratory reserve volume, inspiratory reserve capacity. Okay, those are some of the things which are going to make up. Those are the three things which are going to make up the lung which are going to make up the vital capacity. Okay. The next thing is the air that is trapped in the lungs is called residual volume. Then we also have now what we call total lung capacity. So total lung capacity. So total lung capacity is a combination of four, where we have the residual volume, the vital capacity, and the tidal volume, and the inspiratory reserve volume. Those are some of these four are the ones which make up the total lung capacity. But in pregnancy, the total, the tidal volume, the TD, goes up while the other three decrease. Okay. Then the minute ventilation, which is the volume of air moved by the lungs in 1 minute, decrease. Then the respiratory rate plus the tidal volume, then the tidal volume is one which is just going to go up by minute ventilation. Then the partial pressures of carbon dioxide goes down due to respiratory alkalosis, and pH goes up. Then urine pH goes up, and that results in UTIs. So you find that there will be recurrent UTIs due to the urine pH that has gone up. Okay. Then hematological changes. So hematological changes, you have to know that one of the hematological changes is that the RBC mass increases by 30%. Then the plasma volume, like we talked about, so the plasma volume has increased by 50%. Okay, then the RBC mass, we said it has increased by 30%. Then hemoglobin and hematocrit are going to increase, so hemoglobin and HCT are going to decrease. Then the WBC goes up, so no more up to 16,000 or up to 16. That's the normal in pregnancy. Then ESR also goes up, so ESR goes up. Then fibrinogen concentration also goes up, so there will be reduction in plasma fibrinolytic activity, so the fibrinogen concentration goes up. So factors such as factor 7, 8, 9, 10, which will make someone to have the risk of thrombosis. Also, for those factors go up as well. Then so the patient goes in a hypercoagulable state. Okay, then platelets usually remain unchanged, and the HB is the lowest at 30 to 32 weeks. So that's a physiological anemia. So it's called a physiological anemia. So we talked of the factors as well. So the factors we have talked of 7, 8, and 9, and 10. Okay, the platelets remain unchanged. In physiological anemia, those are some of the hematological changes. Okay. Then after the hematological changes, we can talk of the GI. So the GI, where we have the smooth muscle tone goes down, resulting in decreased motility. Then that's a smooth muscle tone. Then the emptying time. So the emptying time goes up, and the residual volume of the stomach goes up. So this is going to result in reflux esophagitis, cholelithiasis, and constipation. Okay. Then the renal changes. So the renal changes, first we are going to start with the anatomy and then the physiology. So there will be in terms of anatomy on the renal system, the kidney sizes, so size of the kidney are going to increase. Then the renal pelvis volume increases. the ureters increase in size, which may lead to hydronephrosis, and the implication is that there will be stasis plus increased pH is going to also again further lead to UTIs. So there will be stasis after these things increase in size. So the kidneys increase in size, the renal pelvis volume increase in size, the ureters increase in size as well. Then there will be stasis plus the increased pH to lead to UTI. Then in terms of physiology, the renal physiology, there will be increased clearance, then there will be increased renal plasma flow, then the glomerular filtration rate is going to increase, then the creatinine clearance also increases, then the BUN increases, the serum creatinine goes down. So the serum creatinine goes down due to the increase in creatinine clearance. Then uric acid decreases, and there will be an increase in the spillage of glucose. So there will be glycosuria. So the reason why there is glycosuria is because that normally in the kidneys there is what we call the glucose renal threshold. But in pregnancy, that glucose renal threshold is going to decrease. Hence, there will be spillage of glucose in urine. So then someone end up having more of a physiological glycosuria. So due to a decrease in the renal glucose threshold. Okay. Then the other renal changes you might see, you can have a blood flow that increases. So there will be increase in blood flow to the kidneys. Then of course the glomerular filtration rate, as like we talked of, is going to increase. Then that's the things about the renal system. So you have to know that there will be a physiological glycosuria due to the normal decrease in the glucose renal threshold. Okay. Then in terms of the endocrine system, which is from the pituitary, specifically the pituitary, there will be an increase in the increased blood flow. So blood flow to the pituitary is going to increase. Then if there is hypotension, there is a risk of pituitary infarction called Sheehan's syndrome. So Sheehan's syndrome can come from PPH and APH. So this is due to the increased, if there is a sudden decrease, since normally there is an increased blood flow to the pituitary. So if there were to be hypotension, then there will be risk of pituitary infarction. Okay. Then in terms of hormones, prolactin failure of lactation. So there will be luteinizing hormone, follicle stimulating hormone, and the ACH. Those ones are not necessarily going to be there. Okay, it's because of there will be other hormones now taking over, such as progesterone. Okay, then in terms of the thyroid gland, so the thyroid gland, from the thyroid gland, there will be, so thyroid now, so we are now talking about the thyroid gland. There will be, so in terms of size, so the thyroid gland is going to increase in size. Then the T3, T4, so T3/T4 are also going to increase. So normally in pregnancy, T3, T4 are going to increase. Then the free T3 and T4 does not necessarily change. So, but the free T3 and T4 won't change. So, okay. So when you have thyrotoxicosis in pregnancy, just have to bear this in mind. Okay. Then other changes, such as the from the fetal secretion. So fetal secretion. So in utero there will be shunts. So in utero, in terms of fetal secretion, there will be shunts. There will be the ductus venosus, which is the umbilical vein to the inferior vena cava. Then there will be a foramina ovale. So that was the DV. Then FO, which is the foramina ovale, which is the right atrium to left atrium. Then there will be the ductus arteriosus from the pulmonary artery to the descending aorta. Then you can use endomethacin drug that can cross the ductus arteriosus, if at all if it was patent for some reason. Okay, so it becomes patent for more than 3 days. That's only when you can try to do this. Okay, so that's basically the end of the literature review. You can now go through the questions themselves and the answers. So clotting factor decreases in clotting factor that decrease in pregnancy. So which one are going to decrease in pregnancy? Okay, so from what we have learned, so most of the other clotting factors were going to go up. So which one is going to decrease? So the answer here is C. So uh, clotting factor 13, that's the one which is going to decrease in pregnancy. Okay, then the next question is, which one of the following is the least likely physiological change in pregnancy? So the answer here is D, which is an increase in peripheral vascular resistance. So remember, under the cardiovascular, we said the peripheral vascular resistance is going to go down. Okay, then what are the maternal physiological changes in pregnancy? So an increased cardiac output. Of course, there will be an increased cardiac output. There will be an increased tidal volume. Then we said the other thing we said will be an increased plasma protein concentration. Those are some of the. So there will be a decreased. So that's that's a decreased. If this is for decreased, then where it's written IJ, that's increased. So decreased plasma concentration. Okay, then the next MCQ was physiological changes in pregnancy. So which one now? So be decreased result volume, then also the hematocrit is also going to decrease. Okay, that's some of the things you have to know. Then which of the following cardiovascular changes is abnormal in pregnancy? So right axis deviation on ECG, that's one. Then D, which is early diastolic murmur. Those are some of the things which are correct on these MCQs. Okay, so that's basically it on the physiological changes in pregnancy. Thank you for watching. If you haven't subscribed, please subscribe and hit the bell notification, and check out the next tutorial and previous story videos as well. Thank you for watching. See you on the next tutorial.